I'm going to talk a little bit about why we put in EVDs. There's a couple different reasons. So generally the reason that we put in EVD, or external ventricular drain, or ventriculostomy catheter, or whatever you want to call it, is typically there's some sort of obstructive problem going on. So either somebody's had a tumor, brain tumor surgery, and maybe when they first came in, they had evidence of a backup of spinal fluid on the brain. And so because of that, until we could temporize them until surgery, we would put in these EVDs in order to relieve pressure, right? So if you think about the brain, it's enclosed inside the skull. You've got brain tissue, you've got spinal fluid, and you've got blood inside the blood vessels, okay, called the Monroe-Kelly doctrine, if anybody's ever heard of that, right? So anytime somebody comes in and they've got a tumor and it's large and or it's compressing one of the ventricles, it can cause this backup of spinal fluid, it can cause a change in their neurologic exam. EVD goes in for that reason. So that's one reason. Another reason is ruptured aneurysm. So patient comes in, they've ruptured an aneurysm, they've got blood throughout their entire subarachnoid space, and then there are structures in the brain called the arachnoid villi, which can't reabsorb the fluid that's typically made. And so basically you're still making spinal fluid, you can't reabsorb it, and that causes the pressure to go up. And so they'll get the headache, the nausea, the vomiting, and then they'll become sleepy, and then potentially that can kill them. So that's another reason that you will see, and that's probably the most common reason that we put in external ventricular drains or ventriculostomy catheters. Third reason would be if someone has had a brain surgery and we're using it for wound healing purposes, meaning that let's say somebody had a cerebellar tumor, you know, we first put in the EVD to help with surgery, because as we drain off that spinal fluid, it allows us to access the back part of the brain easier and allows the tumor surgery to be a little bit safer, because it takes a little bit of pressure off and we're able to access the tumor easier. And then we'll leave it in after surgery for sometimes 2 days, sometimes 3 days, and basically what it's doing is diverting fluid away from the incision and allowing that incision to heal. Because one of the biggest risks, specifically with posterior fossa brain tumors, is a CSF leak. And so by having that drain in place, it keeps the pressure on the lower side, it prevents that from potentially happening, and then so that's another reason that we will have external ventricular drains in. Any questions about any of that? We sometimes will do lumbar drains for subarachnoid patients, which it's a similar process but a little bit different from that standpoint. And so we should have brought one down. I didn't think about that. We could have brought a lumbar drain down. But those are the main reasons that we put in the drains. This is typically what the drain setup looks like. This is an AccuDrain company called Integra. This is the one that we most commonly use. As Lacey pointed out, we're having a lot of trouble getting this particular drain in because of access and staff, or access to this particular drain. I don't know what it is, COVID, whatever it may be, but so this is the most common one. Typically, what you do in order to set this up, and Terry can kind of go into what the nursing side of things does, but basically you're going to flush the system with sterile saline, right? So you want to make sure you have your transducer on, but when you flush it, you can use this port here, and so you want to turn it off to the patient if you have it, and then you want to flush through the system. And what you're trying to do is just basically make sure that there's no air bubbles in the system. If you see any air whatsoever, then you might need to flush it more, because any air that gets potentially trapped in there can cause an abnormal ICP reading, or it can cause the inability of flow of spinal fluid out. I'll let Terry go over the specifics of that. In terms of, usually we're going to level this at the ear, or the external auditory meatus. You're leveling it at the ear, and that's the transducer. And basically from that standpoint, we're able to measure ICPs. We're typically going to measure in millimeters of mercury is usually what we like to set it at. You can do centimeters of water. The conversion is a little bit different from the monitor because most everything is in millimeters of mercury. So when you have this set up, you've got it leveled on the pole. We're going to tell you to set it at a certain number. Usually that's going to be, oh, did that break? Oh, perfect. Nice.
That's not supposed to happen.
That sounds good. But usually we're going to set it at a certain number. The easiest way to do that is squeeze this wonderful contraption that is broken. Thanks a lot, Lacey.
Feels a little bit better now.
And so this is going to be hooked to the patient. Generally speaking, I tell people to leave this stopcock alone. I've had the most experienced of nurses call me in the middle of the night saying the drain's not working, ICPs are going up, and you come in or somebody comes in to look at it, and you're like, oh, let me take that off being clamped, right? It happens to the best of us, but just leave this particular one alone. A lot of times we'll use this to access CSF. Generally speaking, if you're going to clamp it, I would use this particular stopcock here. That way, you're only using one. You know if there's a problem, then this is the only one you're going to be looking at. And essentially, you know, like I said, I'll let Terry get into how you're going to set all this up. But here's your transducer. You're going to get a number on the monitor. We're traditionally not worried about the specific number per se. We're just making sure that this is working appropriately. So if it's dripping and you come in and you check it and ICP says it's 18, I don't care, right? And more important is what the patient's doing on exam. So sometimes I'll get phone calls that'll say, oh, well, I just checked their ICPs and it's 20. I'm like, okay, is the drain working? Good. All right, is the patient neurologically the same? Fine. I'm not really worried about that.
Do you still want a phone call if the drain's working and neurostatus is unchanged, but ICP is...
Not for one number of 20. No, I don't necessarily need a phone call. I mean, usually when we're gonna want that phone call is if we've clamped this, and then basically the ICP's staying above 20 for more than 20 minutes, or if during that time frame the patient's had some sort of neurologic change, right? Now sometimes it gets to the point where people are just running in the 20s. They're perfectly fine, right? And you're not doing anything about it. We may tell you to stop monitoring the pressure and just follow their exam. So it's really based off how the patient is doing, not just the number. But certainly if you're having a problem or you're concerned, I mean, always we're gonna take that phone call, sure. If you start to have a problem where the drain's not working, so what do you do when the drain's not working, right? So a couple of different ways to kind of troubleshoot it. And most of the time we're gonna tell you to make sure that one, the stopcock is open, right? Check your line, make sure that there's no air bubbles or blood or sometimes brain in the line, right? Because you will get brain in there that will clog it up, that happens. And so if all that looks clear, then you want to take this off with the pole and then drop it to the ground, right? And by lowering it, as low as you possibly can, you're wanting to see if that fluid's going to drain out. If you're still not getting fluid, then that's going to be a phone call to us to say, hey, look, this isn't working. I've dropped it to the floor. I can't get it to do anything, and it's still not draining for the last 2 hours or something, right? And you don't have to call us right away in that first hour if your patient's fine, but 2 hours are going by and you're not getting anything, it's probably good just to give us a heads up. And if somebody has a EVD and they're having a neurologic change and for whatever reasons it's not working, you don't have to call me, as far as I'm concerned, to tell me that they've had a neurologic change and that their EVD's not working. You can go on down to CAT scan and call me at that time, because that's probably what I'm going to do anyways, especially if they've had some neurologic change. I mean, those are the main things as far as troubleshooting goes, looking at your stopcocks, making sure that they're all appropriate, looking at the line, making sure that there's no blood or air or anything else in there that could have caused it. Sometimes they can become disconnected, so that happens, right? So what happens if this piece comes disconnected from your catheter? So you want to grab a Kelly or some sort of clamp, whatever you guys call that, and you want to clamp off your EVD catheter because you don't want that fluid just running out, right? So you clamp off the EVD catheter. Common mistake is that you want to put this back together. Don't do that. There's a risk for infection. Okay, so just clamp it, call us, let us know what's going on. Obviously, if we think it's something that needs to be dealt with, then we'll come in and fix it, or we'll just say, hey, watch their exams, see how they're doing. And so you don't necessarily have to rush in to fix it. But we'll come in the next morning, and then what we'll do is sterilely cut the catheter, and then we'll get a whole new system and put it back together. But is it the end of the world if you put it back together? Probably not, but the safest thing for the patient is to clamp it off at the from the orange catheter that's going into the brain, and then allowing us to come in and fix it, because that's a common thing that happens. What do you do when you pull it out, right? Or a patient pulls it out, right? Well, number one, you just oh fuck, I have to call the neurosurgery team and tell them, the drain's out, right? So obviously letting us know, but you're gonna want to hold pressure on wherever it came from, right? Because you don't want spinal fluid just leaking out. If you need to wrap their head or something, you can do that. But it's going to be a phone call because a lot of times we have to put a stitch in, depending on how bad the fluid is leaking from the incision.
And do a neuro assessment, hope you don't have to put another drain back in.
Well, yeah, you're going to be calling us. We're going to be asking you, how's the patient, right? What's the exam? And then we can kind of make that determination of, okay, do we need to do something? You're probably going to end up getting another scan for whatever reason at that point, depending on how the patient's doing after talking to us. But that's certainly a phone call if it comes out. You don't want to wait for the morning. You know, we want to know about those things. Even if your patient's doing well, you should call us, right? Trying to think. Terry, what other questions have you seen from
I'm thinking those are the
nursing?
big things. A lot of the times, like you said, what to do if it comes out, checking all your connections. I mean, normal troubleshooting stuff,
Yep.
making sure you're unclamped, all that stuff, seeing if there's air in the line, dropping it to the ground. I feel like those are the biggest things you're going to run into.
Yeah, and then it becomes disconnected
Yeah.
from the catheter. That's probably
I
the
was
best
gonna say,
thing.
that's about all I can think of off the top of my head. That's the most common things.
Did you guys have specific questions, or have you guys had experience with EVDs that you've had questions regarding, or? No?
I think so.
Annette, what do you get most questions about with regards to?
We haven't been seeing a whole lot
That's what I was
of
gonna
We haven't
say,
been as
yeah.
busy lately with,
Yeah.
particularly with drains, so.
Yeah, I know
some-
the OR was not putting the transducer on, and they
Yeah.
are now.
Okay.
So when they would go up to the ICU, they were looking at the nurses like, well, why are you all not transducing this? And I
Yeah.
don't want them to flush the transducer and do all that. I'm like, I'd rather you all not get someone to do that does this all the time and is pretty
Sure.
comfortable with that.
Right.
So I believe the OR is now putting on transducers correctly.
But I imagine it'll probably stay that way because most patients with an EVD we don't keep down here for greater than
Right.
an hour, 2 hours. So
Sure.
and previously we've never transduced anyways. Even if they have the transducer on, I can't imagine
The only time
that.
you would transduce is if the patient was boarding in the PECI. Yeah. So that would be a situation where you would have to transduce.
Sure.
The other
So
big thing,
That would be the main thing.
Speaking of that-
Or there's neuro something going on, cause then it'd be like, what the heck's going on with my patient? And if you have that,
Sure.
and there's something neuro, by God, you better be transducing.
Right.
And seeing what's
But
going
typically you guys are coming out with the patient and telling us that you want to transduce.
Right, but yeah, so if the patient's being boarded, right, and you give me a call that I've got some sort of neuro change, then yeah, I'm gonna wanna know what the pressure is. You know.
on. What were you gonna say?
biggest thing we saw that was a problem a while back, that transducer should never have
A pigtail,
a pigtail
ever.
on it.
And
We
if that
had,
happens,
like-
we need to address that with the OR.
Yes,
'cause
correct.
What do
We're
you
saying
mean
those
pigtail?
shouldn't even
So
be
they were hooking up the A-line transducers, not the EVD
with the flush.
transducers.
Oh, I see.
So
That
with
little
the
thing.
A-line,
I
it
got
has
you.
that pigtail
Yeah.
on it.
Yeah, and
And
hopefully that's not.
hopefully, yeah, and we would realize we don't want
And let us know
open the
that
pigtail.
immediately, yes,
to go back to the brain.
right.
And then Terry, if you wanna go over all
Yeah.
the, how you're gonna.
I can do that.
Pressure and then like flushing it.
Thank you, Chris.
Oh, you're welcome.
Yeah, thank you.
Yay,
We
give
have-
Chris a round of applause, good job.